All right, so it's week 8. It's the fall. It's Thursday's lecture that you guys missed because of Turkey Day. Here we go. We're starting the lungs. The lungs, of course, live inside the thoracic cavity. They usually cover the heart a little bit here. Okay, remember the right lobe has 3. It has an upper, middle, or superior, inferior, and middle lobe, or sometimes it's called the upper, lower, and middle lobe. The lungs live in the thoracic cavity, of course. They're bordered by the diaphragm below. So they sit on the diaphragm. Don't have to worry about all these pieces, but we can see a nice middle lobe here. I mean, there's a horizontal fissure, right, and an oblique fissure on the right lobe. The left lobe does not have a horizontal fissure. It has the oblique fissure. And it doesn't have the middle lobe, right? The whole middle lobe is not there. There's kind of a remnant of the middle lobe called the lingula right here, but there's no fissure that separates that from the other parts. Anatomically from the back, I mean, this would really be kind of a medial to lateral view. You can see the parts again. You can't see the horizontal fissure very well from this view. And in fact, clinically, we don't even acknowledge when you're doing the back of the lungs, you're auscultating the back of the lungs. We don't even acknowledge the existence of a middle lobe, right? So the diaphragm in the base of the lungs is typically about T10. That is about where the lats not quite end, but they're starting to end. The concept of the pleural cavity is important. Just like the heart, the lungs are also encapsulated by a layer of a serous membrane, and we call that the pleura. So we have a visceral pleura that is stuck to the lungs. If you take this area here and blow it up, you can see a visceral pleura right here. And then the chest wall, that innermost intercostal muscle, is lined with another pleura. That's called that's the parietal pleura. And there is a space between these where this is filled with serous fluid. Right? But this is the all-important pleural cavity, and it's similar to the pericardial cavity, similar to the peritoneal cavity, the 3 Ps. It can get filled up with fluid, right? If this starts filling up with too much fluid, it can start to push the lung in if this is all fluid. And that's called the atelectasis, specifically a compression atelectasis when this fills with fluid. Or maybe you get a puncture here and it fills with air. So you can get a pneumothorax. Hydrothorax is when it fills with serous fluids. If the cells get irritated by a bug or cancer, it overproduces serous fluid, and you can get an atelectasis from that. Could fill with blood. Hemothorax. Tracheobronchial trees, an important concept. I think we know trachea is straight and it branches off into about 23 branches. And in fact, this is an important concept here where the trachea has 23 branches. And the first 16 branches are considered the conducting airway, conducting zone. No gas exchange occurs here. But once you get down into these last 17 through 20, or really there's 3 main parts. This is called the respiratory zone or the respiratory unit, because this is where gas exchange occurs. All right, I'm sure you know that by now. The alveoli are like little grape clusters. They have a duct. They communicate with these alveolar ducts, which are also filled with these alveoli. And you know the deal, right? You can go to my review on this video, which you're going to need for next week anyway if you shake hand this stuff. All right, let's get into the lung exam. So we have inspection, palpation, percussion, and auscultation is the pattern. There's 2 parts to this. We examine the posterior thorax, which is more time-consuming, and the anterior thorax. Some reference lines, I think we know these. We definitely better know the midclavicular line. Remember, we said the fifth intercostal space is typically right just a little bit below the nipple and inside, although you're not supposed to use nipples because they can be anomalous. Mid-sternal line, we know. Anterior axillary line. Let's look at these axillary because we talked about this with Traub space, right? There's the mid-clavicular, mid-axillary line. There's an anterior axillary line, which goes through almost the middle of Traub space. Posterior axillary line, I don't use that for anything, but there it is anyway. And we have a mid-scapular line and a vertebral line. Doctor positioning. So for the posterior exam, which we're going to start today, the patient will be seated. Now watch out for this. The doctor is actually, for the first time, on the left side of the patient, right? Normally the doctor's on the right side of the patient, but not for this exam. For the anterior pulmonary exam, the patient will be supine, not seated. In this exam, the patient will be seated with their arms kind of folded to move the scapula out of the way. The doctor will be on the left side. All right, let's start this posterior pulmonary exam. So again, this is how we break this down, just the right and left upper lung fields or upper lobes and the right and left lower lobes. We don't worry about an intermediate lobe on the right here because it's just too small to see. The base, again, is at the level of T10. General inspection is first, so the patient should be disrobed for this to be done. Look for deformities, skin lesions, skin cancers, injuries, scars, things like that. Also, from the anterior, look at the trachea to make sure it is not deviated to the right or the left. There's a resorption atelectasis that can occur, especially in people with chronic bronchitis or asthma, where you can get a sucking of lung tissue. The lung can collapse from the inside out. So you get a compression atelectasis where it pushes the lung in, or you can get an absorption or reabsorption atelectasis where it sucks the lung tissue in. You probably had these before, but make sure you know these if I whip them on the test here. People with COPD tend to have a barrel chest. Normally, the ratio is greater in the lateral kind of division here compared to the A to P division is shorter. So the ratio of A to P diameter to the lateral diameter is about 0.8 on average. If they have a 1-to-1 ratio, that's a barrel chest, and that's associated with COPD. Mainly emphysema is that part, because remember, COPD, chronic bronchitis, and emphysema are both members of COPD. So emphysema usually causes destruction of tissue, causes that. Then we have the funnel chest and the pigeon chest. So the funnel chest, it can interfere in kids. It can interfere with heart and lung development. We really don't know what causes it. It's the costal cartilage, though. It's not usually the ribs that is the trouble. It's a weird growth of the costal cartilage. In third world countries, it could occur from vitamin B deficiency, but we don't really understand it. And that's called pectus excavatum, like an excavator has been digging here. Then the opposite is pectus carinatum. That's the pigeon chest. And again, we don't know for sure what causes it, but it's can mess up lung development in little kids. Breathing, the rate is 20 to 14. The breathing should not be labored. You should not see accessory muscles or retraction of the intercostal spaces, which indicate accessory muscles are going. If you've ever seen an asthma attack, you can see all their strap muscles in the neck and the SCM, and the intercostal muscles are sucking in. It's the weirdest looking thing. You shouldn't see that, right? They're in distress if you see that. Watch out for adventitious sounds. We'll talk about this more next time, but there's 3 main adventitious sounds. Wheezing associated with asthma. It's a 400 hertz. It should be HZ. 400 hertz sound. It's only heard usually on expiration. Crackles sounds like Velcro being pulled apart, which is usually heard on expiration. It could be heard on inspiration or expiration, actually. There's two different types of crackles. Pneumonia, so wheezing, think asthma. Asthmatics wheeze. Crackles, classically you should think pneumonia, even though interstitial fibrosis actually has more chance of developing crackles, but it's not a very commonly known one. And then they're trying to get rid of rhonchi because it's really not an adventitious sound. It's usually seen in people who are close to death and they don't have the power to clear the normal phlegm and mucus out of their tracheobronchial tree. That's why it's called the death rattle. It's about 200 hertz. It's a lower pitch sound. We'll go over these somewhere else. Maybe is it next week or maybe in lecture? But yeah, that's called the death rattle. Also look at the fingernails. Remember, clubbing of the fingernails is associated with lung cancer and other lung tumors and other diseases. Like we studied it so far, talking about ASD and VSD with Eisenmenger syndrome. And yep, it can happen in Crohn's. We haven't studied it, but we'll look at it again in Crohn's disease. And definitely affective endocarditis. That was the first case of it ever reported, was infective endocarditis. And then it can be just an abnormal genetic trait. You do have to have it worked up. I've had a handful of students over the years have this, and they were all fine, but you have to send them to get them worked up because you just don't know. It could be lung cancer starting, or unusual in people your age, but you got to get it worked up. Palpation of the posterior thorax. So that was inspection. Now we're starting palpation. There is no palpation. There's no soft. Remember, in the abdomen, there was a circular soft palpation, and there was a back and forth deep palpation of all the quadrants. There is no palpation like that here. The palpation is used to categorize 3 tests. So these are the palpatory tests that we're going to talk about. The posterior chest expansion, posterior tactile framatus, diaphragmatic excursion. Again, you've been taught these not based on the board book, so I will show you exactly how the board books say to do these. And that's how I expect you. I will not accept if you do it the way you've been taught in other classes. I won't be happy with that. Posterior chest expansion test we'll do first. So this one, there's no measuring tape involved. They made this out to be harder than it really is. Bates and Seidel and even Jarvis all say to do it the same way. So the key is to put your hands out and then grab the patient. You want to grab the patient by the lower rib cage here, and then you want to bring your hands together while you're still holding. See, she's still kind of digging into him. And you want to bunch the tissue. If you do this right, you should get a tissue, kind of bunch up the tissue here. Then and you're still grabbing onto the patient. Now your hands are really stuck to the patient. Now you have the patient take a deep breath in, and you watch the thumbs as they go apart. Normally the right and the left thumb should symmetrically move apart during inspiration and move back together during expiration. That's the test. There's no measuring. You don't do it up higher either. This is the test. So normally the thumb should move symmetrically. There's some interesting findings which have some pretty good clinical significance to them here. What if they don't move apart normally? So that's a positive. They don't move apart normally, and you should note which thumb doesn't move and lags behind the other. Which one's kind of stuck? Look at this crazy number. So Bates, board book, McGee, super evidence-based clinical exam book. The positive likelihood ratio for the patient having unilateral lobar pneumonia, meaning an infection within one lung that hasn't spread, or within one lobe that hasn't spread to the other lobe, It's 44%. That's outrageous, isn't it? Anything over, 8 is great. Anything over 10 is almost certain that the patient has the condition. This is a great way to catch lobar pneumonia. The side with the pneumonia won't move, or move very little compared to the other side. Pleural effusion is good, 8.1. Where does the pleural effusion come from? Probably from the pneumonia, which has broken out of the lung and gotten into the pleural cavity. Others, chronic fibrosis, unilateral bronchial obstruction, paralysis of a heavy diaphragm, could be possible as well. But the big ones are here. Remember, pneumonia. So that's our second one for pneumonia, right? We talked about oscillatory sound. We'll talk about that more next week. But the oscillatory sound for that was crackles. Okay, tactile framatus. This is 99. It's also called vocal fremitus. And it is you say the words 99, 99 in a deep voice. And that creates a low frequency sound wave that should travel equally through the tracheobronchial tree, through the parenchyma of the lung, through the pleural cavity, and through the chest wall into your hands. And we can use that to look for mainly for tumors and pleural cavity effusions. All right. So everything I said there. So just like with the cardiac exam, looking for cat purring for thrills, we're going to use the ball of the hands again to detect this. And so you can use a knife edge as well. Where's the picture? Here we go. So you're going to start up here in a reverse L pattern. You're going to put the metacarpal phalangeal joints right up here. Have the patient say 99. Then you're going to go down here between the scapula. The hands would be like this. You probably use a knife edge here because you're not going to do any good if you're on the scapula. Probably the knife edge. She might go up a little bit higher there. But you can put the hands down here for a third place. And then don't forget to go out here in the apices. All right? And that vibration should be normal from side to side. Right? So that's the reverse L pattern. This reverse L pattern is a little modified. This is the oscillatory and the palpatory pattern, which is very similar, but it's still reverse L's, meaning don't forget to go out in the costophrenic angles. That's the mirror L pattern. This is not for tactile framatus, though. This is the pattern. Where is the pattern? Here it is. Got it in the wrong place. So here's the pattern I just showed you. Right? So if I ask you to do tactile framatus, patient already has their arms crossed to get those scapulas out of the way. That's exactly how you do that. Right. Okay, so what's a normal finding? You should feel the exact same vibration in the right hand as you do in the left hand. By the way, this is a little different. It used to be using one hand only, and now you can use two hands. Both the two board books, Seidel and Bates, both have it now as doing comparison with both hands. Okay, so it should be the same amount of vibration. If there's not vibration or there's excessive vibration, that's a problem, and you should note that. So what causes decreased vibration or decreased fremitus or decreased vocal fremitus? Well, maybe they're just talking or not using a deep enough voice, so that would be bilateral loss. If they have hyperinflated lungs from COPD, the hyperinflated lungs have so much air it doesn't transmit sound very well. So you'd have most likely bilateral fremitus loss in someone with COPD. Pleural effusion, you might have a unilateral loss. The effusion pushes the lung tissue. Anything that pushes the lung tissue away from the chest wall decreases the transfer of fremitus across that space. I always had a little trouble with this because it's mostly water, serous fluid, And water transmits sound very good. So I'm telling you the way the board books have say this, but this is a problem for me because I would think pleural effusion would transfer it just fine, if not better. But nevertheless, they say pleural effusion doesn't transmit good. I'm sure they've done studies on that, but that doesn't make sense to me. All right, Piothorax. Now that one makes sense because pus is probably not going to transmit fluid, but it's probably still got a lot of water content, and same with blood. Pneumothorax makes perfect sense, though. If you have air in the pleural cavity, then that makes sense that you won't transmit fluid. In fact, that's the one I would remember here. Or cancer in one lung that's gotten into the pleural cavity. How about an increase in fremitus? Well, pneumonia is associated with an increase in fremitus because water does, especially a wet lung, transmits sound really, really well. So you would feel almost like thrills, really strong purring sound in someone with unilateral pneumonia. All right, so just a recap about our lobar, a pneumonia isolated to, well, you pick the lobe. How about the right lower lobe? They would have decreased chest expansion on that test. That's a likelihood ratio of 44. That's probably enough right there. They would have increased tactile framatus on the side with the lobar pneumonia. And then auscultatory, when you auscultate that, you may hear crackles. We'll talk more about that next time. Okay, percussion now of the posterior thorax. So Bates says this is one of the most important techniques because it does penetrate down about 7 centimeters, which is pretty far. That's farther than heat and ultrasound and things like that. So you might be able to pick up a lung tumor if it's close enough to the surface. You can also pick up air and fluid and things like that. So let's look how to do this. The key is to make sure your finger is parallel with the floor or perpendicular to the ribs. You want to try to get your finger in between the ribs, intercostal spaces. If your finger's going this direction, then you're over the ribs. You're not going to get a very good percussion note that way. So make sure they're parallel to the ribs, parallel to the ground. Is that right? They should be, yeah, sorry, I said that wrong. They should be parallel to the ribs, perpendicular. No, they should be parallel to the ground as well. Right? It shouldn't be perpendicular because there's the ground, so you're parallel to that. So I need to fix slide 46. So, because the ribs basically are parallel to the ground anyway in your fingers. So let me actually write that one down. Percussion notes. The normal percussion note we know is resonant, except for Traub space, right? We know that could percuss as tympanic, or at least part of the Traub space should. You should find dullness at the level of T10 when you hit the diaphragm, and when you hit the liver, might be a little bit higher. Might be a little higher dullness on the right than the left. The pattern is going to be the same for auscultation. It's the same as the vocal fremitus pattern as well, but it's a little bit more involved. We added a spot here, and we added a spot here, and we added double spots out there. So make sure. Now this time you're only going to you're going to percuss side to side. That's the key. You don't have to use this exact pattern, but you need to percuss here, and compare those percussion notes. Percuss here, percuss here. I don't care if you jump over here and here, or I don't care if you go down like that, but go straight down, get all those percussion notes, and then go out here and make sure you get the costophrenic angles. These are probably the most important. All right, so we're percussing all those to make sure the percussion note is the same. Possible percussion notes. Well, resonant. It should be, in fact, everything should be resonant on the back. There's no cardiac dullness or liver dullness that we're going to hit. When we go to the front, we're hitting a lot of dullness. Except on the front, we know we have Traub space that could percuss as tympanic. sometimes there's a hyperresonant sound where it sounds ridiculous, like you're really beating a drum. And patients with emphysema tend to have that. Pneumothorax, I'm not sure I understand that one that well, but definitely COPD. You can be hyperresonant. Dullness, we already know, the cardiac dullness, the liver dullness. Over the scapula, that's dull. What are the causes of asymmetric dullness? Could be that pneumonia again. That pneumonia is going to percuss dull, 3 times more likely to have pneumonia if you detect dullness over the lung. We're picking on that right lung. Wasn't it the one we used, right lower lobe pneumonia? So you go over the right lower lobe and it's dull compared to the right. That will increase your chances. 3 times more likely to have pneumonia. 4 times more likely for a pleural effusion or hydrothorax, hemothorax, pyothorax. Anything in filling up that pleural cavity is not a good thing. And let's see, asymmetric hyperresonance is COPD. It could be unilateral or bilateral. It's probably going to be bilateral. Usually they have COPD in both lungs. Causes of hyperresonance, again, COPD. And, hyperinflated. We'll talk about COPD next week. A large pneumothorax might do it. Or a bleb, which is usually part of COPD, or honeycomb lung, or something like that. All right, this is, if you're going to mess up a test, you guys have trouble with this test. So this is diaphragmatic excursion test, and I'm not sure if you learned this test. This might be new. But when everybody take a deep breath right now. Feel your ribs expanding. They're expanding because your lungs are expanding. And blow the air out. Feel your lungs collapsing. They're collapsing because the air is collapsing out of them. So your lungs have the ability to contract and expand. And we can measure that kind of in a straight line on the back of your lungs using a percussion technique. And in fact, come to find out, we can measure the diaphragm, the excursion of the diaphragm. When you blow the air out, the lungs usually go to about 3 centimeters or so. When you suck in, the diaphragm goes up. When you blow the air out, I'm sorry, I got this messed up. When you blow the air out, the lungs go up, right? Let's draw it here. So if you blow the air out, your lung shrinks up. So there's your lung. If you expire, there's your lung. If you inspire and you suck air in, your lung is going to get bigger. Go down to here. All right? So we can percuss in both states. And we can find the bottom of the lungs will be a dull sound, and we can mark that with a pencil. We can have you inspire and mark that, and we can take a tape measure and measure the distance here in the mid-scapular line. And that is excursion. And studies have shown that most humans have at least 3 millimeters of excursion between inspiration and expiration. Okay, so that's exactly what we're doing. And I guess I should have just went to my diagrams here. So expiration, you're contracting diaphragm. Well, actually, the diaphragm is relaxing, right? When you blow out. And when you breathe in, you contract the diaphragm, and it pulls the diaphragm down, and it makes the lungs expand. It also changes the angle of the lungs, but we don't worry about that. So the procedure, the patient will be seated, and the patient will inspire. And you percuss quickly down the mid-scapular line until you hit diaphragmatic dullness. Take your skin marking pencil and draw a line. Then you repeat, have the patient expire and hold it. Full expiration. Do forced expiration. Hold it and draw a line. Right? Everything I said. and then measure those lines. So the patient took a deep breath in and held it. The doctor percussed down, percuss, and hit dullness here and marked a line. Then the patient blew all the air out and held it. The doctor came down again, percuss, dullness. So this distance looks about 5 centimeters or so. Is the excursion, and that should be 3 to 5, like a 3x5 note card, 3 by 5 centimeters. Really super well-trained athletes, it could be up to 8 centimeters. But we're going to use 3 by 5. Right? These set of markings here, so if you did this on the other side, you might find the same excursion, but they might be down a little lower. Why is that? Well, the hemidiaphragm pushes up these markings a little bit higher, or the liver is pushed up by the hemidiaphragm, so they'll be up a little bit higher on the right side. Okay, so what could cause a decrease in diaphragmatic excursion then? Well, bilateral decrease could be pregnancy or ascites, anything expanding the abdominal cavity. Hepatomegaly would push it up, or would decrease it, but only on the right side, right? And then phrenic nerve paralysis, I don't know what's going on with my computer here, but decreased diaphragmatic excursion, what could cause that? Hepatomegaly would only be on the right. Anything that ruins the elasticity of the lung, like mainly emphysema, will also decrease the ability of the lung to expand and decrease. Right? Anything that decreases or compresses lung tissue, like an atelectasis, will also decrease the ability or decrease the excursion. All right, see you guys later.